Dr. Menon, congratulations on receiving the St. Paul's Medal. I have personally been inspired by a number of robotic surgeons all over the world. And I must say that the two most important to me are you and John Wickham. And both of you have been role models for me. And I'm sure to the other colleagues on this panel, Michael Gorin, Akshay Bhandari, and my colleague at Guy's, Paul Cathcart. So I was really pleased that you followed the ideal principles in describing your way of doing a prostatectomy with a view to improving patient outcomes. Easily the best way to investigate how a new innovation can be brought into clinical practice rather than straight away jump into a randomized control trial. So congratulations on that. The one thing which got me really worried after nearly 20 years of doing this operation is your description of the cavernous nerves at the apex splitting into two and the anterior part going near the dorsal vein complex and into the corpus cavernosa, and the posterior part going into the corpus spongiosum. So I'm not surprised that we have so many patients in the Memorial Sloan Kettering series and the others that you mentioned who, despite our best efforts, never recover their erections after a radical prostatectomy. So do you think we have to deal with the dorsal vein in some other way, maybe not go there at all? I mean, stitching it and then cutting it, or cutting it cold and then stitching it? I mean, I guess we must be taking these anterior nerves in our stitches when we deal with the DB complex. So your thoughts about that would be well.
There are several observations. Some of them are mutually contradictory or mutually opposing. And let me just pose them to the panel and tell you why I think the way that I do. Firstly, why are excellent robotic surgeons only getting a 20% potency rate when these results have been analyzed completely impartially? I mean, they're excellent and they can't be doing the operation 80% wrong. So this makes me think that we don't understand the complexity of the neurovascular bundle. The same surgeons who are getting a 20% potency rates are also getting an 80 to 90% continence rate. And that indicates to me that the neural innervation of the corpora cavernosa is different than that of the urethral continence mechanism. And so that was the basis of this. And we see that in ours too. I mean, the return of continence is far quicker than the return of potency in our hands. Many studies show that there is a hammock of nerves. In fact, almost any contemporary study shows that it's not a single neurovascular bundle like railroad tracks at 5 and 7, but there's a hammock of nerves. The question is, where is the hammock lead to? Our studies, Ash Tiwari's and my study, and Tony Costello's studies, at least the earlier studies, we didn't dissect it beyond the apex of the prostate. So we don't really know where the nerves are beyond the prostate, and those perhaps are critical nerves that lead to the cavernous tissue. Very early studies by Muller, somewhere in 1836, did trace them, and he showed a complexity of nerves. And if you look at his drawings, some of the nerves are anterior. His original paper is in German, and I have a translation of it. He didn't particularly say that there were anterior trunks and posterior trunks, but you can see that in his dissection. And the study, the first study in my mind that looked at the anterior branches was the study from France, where they did do 3D reconstruction of the nerves and tried to see what went to the cavernous tissue. And that showed that the trunk started posteriorly. They fanned laterally and anteriorly on the lateral surface of the prostate. And then they broke into an anterior trunk that went into the cavernous tissue and a posterior trunk that went to the corpus spongiosum. And a subsequent study, a very, very new study, has shown the same. It may be that there is interconnection between the anterior and posterior trunks at the apex. Well, if the anterior trunks are important, and if preserving the dorsal vein is important, no patient who undergoes a radical perineal prostatectomy will be impotent. So how do you deal with that? In a radical perineal prostatectomy, you are underneath the dorsal vein complex. You can't sew the dorsal vein complex because it'll be too bloody, so you just don't get into it. But the potency rates for radical perineal prostatectomy were close to 100%. And clearly that's because the network of nerves is being damaged posteriorly. So just maintaining the anterior trunks doesn't matter, which makes sense. I mean, if they start posteriorly and they fan anteriorly, you would cut them at the back. And again, as you correctly pointed out, if the anterior trunks are all that mattered, then anytime you cut the dorsal vein complex, you're going to damage it, and then you would have a 100% impotence rate, not just an 80% impotence rate. And that clearly is not the case. So I think the more nerves you can preserve, the better. My current thought about this is there are around 4,000 nerves around the prostate. And they are a network. Some of them are posterior, some of them are between the seminal vesicles and the base of the prostate, and some of them are anterior. No surgeon is good enough to preserve all 4,000 trunks, not if you're taking the whole prostate. But luckily, none of us is so bad that we can damage all 4,000 nerves. So ultimately, I'm a country urologist, and I'd like to, dumb it down to my level of intellectual capacity. I think it's quantitative. I mean, if you preserve 3,000 nerves, you will have better potency than if you preserve 2,000 nerves. And if you preserve 2,000 nerves, you'll have a better potency rate than if you preserve 1,000. Some people may only need 1,000 nerves preserved. Some people may need 2,000, but by and large, the better nerve sparing you do, the better your potency is. And I'd like to go away from focusing on neurovascular bundle. That implies that the vessels and the nerves run as a bundle. And that, I think, is where, as Richard Turner Warwick might say, that is what has led us astray, at this point. Not to say that that wasn't a seminal comment, observation that had to be made in 1980, but perhaps in 2020, we should go away from this and look at a more nuanced or subtle or complex understanding of the neurovascular bundle.
Thank you so much. I will go over to Akshay and then Michael, and finish up with Paul Cathcart. Akshay, over to you, please.
Thank you, Professor Dasgupta, for the invitation to join all of you. It's really an honor for me to be here on this meeting with all of you. I do have to say before I go on that I've trained with Dr. Menon for past 9 years. So some of my comments may be a little biased, but for the purpose of this discussion, I've kept them as objective as possible. I will focus mainly on the precision prostatectomy with regards to my comments. So I think there are 3 things that I like about that presentation and 2 things that I don't. The 3 things that I like, first, I think the rationale that the precision prostatectomy was founded on is a very robust one, as Dr. Menon kind of pointed out that, this work, that the precision prostatectomy has come out from over 40 years of many urologists, especially Dr. Walsh, Dr. Menon, trying to improve upon the functional outcomes. But I think the main thing that I think is the strength of the precision prostatectomy is that Dr. Menon performed these whole mount radical prostatectomy specimen mapping studies, which were we published using the IDEAL guidelines. and where we performed how the cancerous lesions are distributed in a radical prostatectomy specimen, especially in contrast to what we call the dominant or the index cancer lesion. And what we found is that if you look at the contralateral side to the dominant lesion, in about only 20% of the patients, there is a clinically significant cancer in the peripheral zone near the prostatic capsule on the contralateral side. So if you were to do a precision prostatectomy, meaning leave behind the prostatic capsule peripheral zone, there is a chance that about 20% of patients you will leave behind clinically significant cancer. So, and to further improve upon that, what Dr. Menon thought is that we should perform dedicated biopsies of that region, because these radical prostatectomy patients were not selected for focal therapy. These were just patients coming for standard robotic radical prostatectomy. So as the second thing I like is that once we had done these preclinical studies to map out the prostate cancer lesions, we kind of reasoned that, okay, in 20% of these patients, there may be something on the contralateral side. So what if we do dedicated biopsies of that region and we don't find any cancer, then it may be safe to leave that area behind. And given in kind of relation to what Dr. Menon described, that the nerves is not a bundle, it's more of a hammock, and it goes from posterior all the way to anterior, and that's what leads to good functional outcomes. So we performed dedicated biopsies, and as Dr. Menon showed the results of the precision prostatectomy, in only about 5% or 6% of the patients at a follow-up of 3 years, we have clinically significant residual cancer in the remnant that we are leaving behind. So I think those are the two strengths or the two things that I like about the talk and the precision prostatectomy study. And the third thing I think maybe Mike will talk about this is I think these are just ideal stage 1 and ideal stage 2 studies that we have done so far. And we are in the process of conducting a randomized control trial. We have submitted an IRB. But I think the main thing I want to focus is this was kind of Dr. Menon's thought, will this procedure work or not? And he wanted to discuss this with patients and do this procedure. And it seems to be working very well functionally and oncologically as well. But the point I'm trying to make is that this is, I think, still in kind of its infancy in this last 4.5 years. And with use of more sophisticated biopsy methods and molecular imaging coming up, I think there is only room for further improvement, both in terms of oncological outcomes for these patients and functional outcomes. So I think those are the 3 things that I like about this talk. And the 2 things that I don't like, one is from, I guess, a trainee standpoint, that I found it a little bit harder to do this procedure, the precision prostatectomy, maybe because it's still kind of developing as we went along. But I did find it harder as a trainee to perform compared to a conventional radical prostatectomy. But again, you, Professor Dasgupta, and Dr. Menon have done robotic surgery and taught it to many people, so you may be the best to comment whether these doubts that I have about the complexity are unfounded or not. But I did feel that way. And the second thing I think I did not like about the talk or the procedure in general is not to do with the precision prostatectomy itself as much as to do with focal therapy in general. I think we talk about the index lesion with quite certainty, but I think, and I do believe in index lesion hypothesis, but I think we are not fully there to diagnose the index lesion preoperatively as much as we would like to. I think in 80% of the patients, we can reliably diagnose an index lesion based on the size and the grade of the biopsy. But I think in 20% of the patients, as we have seen from studies from University of Michigan and other studies, that in 15 to 20% of the patients, we do miss the index lesion because it's not always the largest lesion. But again, this is more of, I think, a drawback of the whole focal therapy paradigm rather than just precision prostatectomy. So I think those were my thoughts about this presentation.
Wonderful. Let's go to Michael Gorin and then Paul Cathcart, and then we'll finish up with a few short comments from Dr. Menon. Michael?
Thank you very much, Professor Dasgupta, for including me in this year's BAUS meeting, and congratulations to Dr. Menon on receiving this year's medal It's really an honor to participate in this panel discussing precision prostatectomy and Dr. Menon's talk. You know, I tend to agree with Dr. Menon's assertion that, you know, we really don't fully yet understand the neuroanatomy that contributes to erectile function. But what does seem to be true is that it's a matter of preserving as many neurons as possible. And the vast majority of these do seem to run along the capsule and the lateral aspects of the prostate. And I think very convincingly he's shown that if one could preserve the capsule of the prostate in some way or another, that this will lead to improved functional outcomes in terms of potency for these patients. I really enjoyed the learning about the ideal framework for surgical innovation through Dr. Menon's work. Admittedly, here in the United States, we don't see many investigators employing this framework, but I believe that Dr. SOOD and Dr. Menon now have used it on two separate projects and have really shown us the benefits of this approach when doing surgical innovation leading up to, say, something like a randomized clinical trial. And I look forward to seeing future use of it in surgical innovation. The one area that I have concerns with the precision prostatectomy or just focal therapy in general are all the concerns that that circle around the concept of the index lesion. Focal therapy really relies on this notion that we could identify the index lesion and that is in fact the portion of the cancer that drives the long-term outcomes for patients. And I really do not feel that we have sort of a firm understanding of whether or not that truly is indeed the case, or how do we even identify the dominant lesion. Sure, if a patient only has unifocal disease, then we've identified it. But as we all know, the vast majority of cases of prostate cancer are indeed multifocal. And so any one of those foci could represent on a biologic basis the so-called dominant lesion. And just simply looking at size and Gleason score does not seem to be enough to really determine which is the biologically dominant lesion. And I really believe in the future, if focal therapy or subtotal treatment of the prostate is going to take off in a way where we can be confident in the long-term oncologic outcomes, we're going to have to employ molecular tools to truly understand which one of those lesions places the patients at greatest risk for oncologic failure. With all of that said, however, I really like Dr. Menon's approach here, where he essentially backs up and says, we don't have the tools to do that, so why don't we just take 95% of the prostate rather than attempting to guess which is the dominant lesion and say ablate that with something like HIFU or cryoablation. And I think that this is a very reasonable approach for where the field currently stands. I do have the concern, though, about this procedure, about generalizability. I believe master surgeons like Dr. Menon, Dr. Tiwari, yourself, Professor Dasgupta, would probably be able to perform this surgery no problem. But mere mortals like myself will probably never be able to perform such a complex surgery like this, or at least I'm not yet convinced that we'll be able to perform a surgery like this. So I think a next area of critical investigation on Dr. Menon's part here is to really investigate the generalizability of this procedure and whether other surgeons could be trained to perform it with similar outcomes that he has been able to show. And without that, we are really just left with the ablative tools that we have, which we know in most urologists' hands could be readily applied, albeit with uncertainty as to the true oncologic benefit that we're doing, given our inabilities to identify the dominant lesion, as I discussed earlier. So, you know, in summary, I think that this is a brilliant approach to the care of men with prostate cancer. I think it solves the problem of preserving as many nerves as possible. It was a brilliant use of the ideal framework for studying surgical innovation. And then the next area of investigation, I feel, should be around studying generalizability, as well as in randomized setting comparison to focal therapy as well as radical therapy. Is this going to be a replacement for focal therapy, or is this going to be perhaps a replacement or a complement in our toolkit to radical therapy?
Thank you, Michael. Let's go over to Paul Cathcart in London. Paul?
Hello, good morning, and thank you for inviting me, Prokar. Fantastic lecture, so thank you very much, Dr. Menon. I learned a lot, especially about the neuroanatomy of the prostate, so I thought that was tremendous. A couple of things. My whole career is very much based around salvage therapy. I'm working with focal therapists, so this actually is a really exciting way forward. Some of the things that I see post-focal therapy would be de novo out-of-field recurrences, and that happens in a significant proportion of patients, albeit those patients tend to have slightly better prognostic tumors, these de novo new tumors. So I'd be really interested to see how one salvages de novo tumors in the residual tissue left behind. And furthermore, in the focal therapy setting, defining treatment failure still hasn't really been achieved. When you ablate, you still have a reasonable amount of prostate tissue that you can see on imaging. PSA outcomes are really not really good enough. And I was wondering what the experiences of MR imaging of this residual tissue is, and how likely you can see those tumors when you maybe got even smaller amount of tissue. Is it even harder to see these new de novo tumors appearing? And if, with regards follow-up, PSA is clearly going to be positive, and so the whole paradigm of salvage radiation is difficult in this setting. How easy is it to follow up these patients? How easy it is to biopsy the remnant areas? I suspect it's relatively easy to ablate residual areas after the precision prostatectomy. I certainly know that that is likely to be possible, but I'd be very interested to see how some of these patients have been salvaged, if any have needed to be.
Thank you, gentlemen. Final minute to Dr. Menon and your final thoughts.
So thank you, Paul, for that perspective. Truly a magnificent summary of where we need to go. But let me answer these issues, the questions that were raised in the way in chronologically. Very simple concept. Try to remove as much of the prostate as you can, and try to remove try to save as many of the nerves as you can. So that's the fundamental principle of the treatment of prostate cancer. Second is that the capsule of the prostate comes from a different embryological source than the prostate itself. So it makes sense, if you could find the right plane, that you could preserve nerves by keeping the capsule, and you could remove the cancer and not compromise it by keeping the capsule. That's just a broad theory. It needs to be refined. Where do we go from here? It's not the hands that need to be trained, it's the mind that needs to be trained. I used to say, much to my regret, I wish open surgeons were more open-minded. They would embrace robotics, and I think that's pretty much where we are here. If you pay a little attention to detail, this will be a very democratic procedure that most people can do. Now, we're still refining it, so I'm not there as yet. The way to do this is just follow the ideal framework. We have applied for an NIH grant, which is a single institution study. If we get funded, I'd hope that Paul and Prokar, and indeed BAUS, would become part of that trial, and we'll have a multi-institutional international trial. And yes, we have to have adequate safeguards. It is easy to miss the planes, and you need a certain discipline to start in one plane and stay in the plane. So we'll have to sit down together and figure out how to do it. But I think it can be done, and I can even predict that the lead of this is going to come from NICE and BAUS and not from the AUA or from me. I'd love to be to work with any one of you who's interested in doing it. You know how to run randomized controlled trials. You know how to accrue the patients. All the tools are there. This is a very small change investment that you will need to do.